All right, let's talk about Chapter 2, Medical Surgical Practice Settings. And this is different ways that an LVN can work outside of a facility. So we'll get right down to it. Community health nursing roles. So community health nursing, if you'll follow with me on page 10 here, it talks about that traditional community health nursing focuses on improving the health status of communities or groups of people through public education, screening for health detection of disease, and providing services for people who need care outside the adult care setting. So these nurses work with many different individuals and groups to create or modify systems of care to improve the health of a defined group. Most roles require a bachelor's degree in nursing, but LVNs are increasingly visible in this community health setting. Even things like the Alzheimer's walk, LVNs can be very instrumental in doing the blood pressures and help screening. If you get a chance to work at the Alzheimer's walk while you're here at Gurnick, do that, because, or any other outside activity, it looks good on the resume, number one, and number two, you can meet all kinds of different people and see all the ways that you help people. We were at a health fair one time, and some students were taking blood pressures, just routine blood pressures, and they found a patient with high blood pressure. Well, he was shocked that it was that high. Apparently he hadn't been following it, as a lot of people don't. They don't take care of themselves. And so he was going to go right away and see his doctor. So that was really a good thing, and it's very rewarding. All right, other community-based nursing, it's based on the community's needs. So some communities need more than others. It may be based on age. Are there more elderly people than at maybe a city like by the bay that has more younger people? It provides various types of care that meets the needs of citizens at various levels of wellness and illness. So we're going to be talking, I think in the next chapter, about the continuum of health and illness. And there's quite a continuum, meaning that there's illness, right? And there's wellness. But there's a lot in between. There's people that maybe psychologically are doing well, but physically are doing well. People that are physically not doing too well, but psychologically they got a real positive attitude. So there's quite a bit of different types of need that can definitely be provided by the LVN. So home health nursing, that's a good avenue for LVNs. You do need to be self-motivated in this type of nursing. You are providing direct patient care. You provide patient and family education, which is great. As a nurse, you're always educating. You're teaching the patient to care for himself, how to care for himself better, how to position his body, how to help himself move. And you also want to always include the family. And education, power. Knowledge is power. So educating the family how to help the patient definitely makes a great team effort. Homes often have only a fraction of the resources of the hospital. Like, who has a hospital bed? Nobody. I know there's some beds out there now that will raise the head of the bed up, and that's great, or raise the foot of the bed up if you've got edema, and that's really good. But if a patient can't get out of bed, then you need somebody to go help them, right? Or at least teach the family how to help the patient. So more must assess patient, family, and environment to plan the care. I remember I had a patient once. She was a rather large lady. She was confined to bed, and so we had to move a hospital bed into a mobile home. Now, picture that one. A big bed that had to be assembled in the living room of the mobile home, which didn't leave much room for the husband. I'll tell you the rest of the story. It's kind of funny, actually, because, she couldn't really, she had a trapeze hanging over so she could move herself around in the bed, put herself on the bedpan and whatnot, but her husband had to work. So he would get like 3 TV dinners ready for her, and he'd just line them up on her bedside table, and then she would just eat them as the time came by. So they did have home health nursing go in and check on her from time to time, but sometimes you just have to work with what you've got in home health. Interesting though, think of the differences that you can make in a patient's condition. So Medicare reimbursement. Medicare reimbursement will reimburse home health, but it's dependent upon 4 conditions. You have to know that there's a need for home care that's authorized by the physician. So there always has to be a physician's order, and it has to be constantly reevaluated if the patient still needs this type of care. The patient needs intermittent skilled nursing or other discipline. Other discipline, I mean like physical therapy or speech therapy. The patient is homebound. Now, the patient must be homebound. That is a Medicare requirement, meaning that they really can't go out of the house. Also, the agency needs to be Medicare certified. Sorry about that. I had to stop for a minute, so let's just go back to this Medicare reimbursement with home health. So the plan of care needs to include a diagnosis, the mental status evaluation. Are they able to stay home? Are they mentally competent to be home? Identification of the types of services needed. Supplies and equipment need to be ordered by that home health agency. So there's always a nurse that will go out and identify what supplies and equipment would be needed in a certain period of time. The frequency of visits, usually 2 to 3 times a week. What's the prognosis of the patient? Is there a prognosis that they could get better, or are they going to need home health for a long period of time? What's their rehab potential? Are they capable of getting a little better? That's always the goal, is return a patient to where they were before. Not always possible, but it's a goal. What are their functional limitations? You've got to take that into consideration. Like the lady I was telling you about, we had to put the bar for her above the bed so she could lift herself up and put herself on the bedpan and help move herself around. Functional limitations, nutritional requirements. We want to be sure that they get the requirements that they need. Medications and treatments, and those would always need to be ordered ahead of time. The care must be skilled, intermittent, reasonable, and necessary. So what I mean by that is skilled care. Care must be the kind that only a nurse trained in that care could be expected to do. So if you're, I believe we're on page here, let's see. So skilled procedures. Skilled procedures include dressing changes, Foley catheter insertions, and venipunctures. But some nursing procedures can be taught to the family, so they're no longer considered skilled procedures. For instance, injecting insulin isn't always considered skilled because most diabetics inject themselves anyway, and the family or the patient can be trained to draw up the insulin themselves. And intermittent visits occur periodically. They usually do not exceed 28 hours a week. Reasonable and necessarily, objective clinical evidence must clearly justify the type and frequency of services. So that's clinical evidence, and this is documentation. Again, how important that is to prove to Medicare, in this case, what is needed for the patient. Also, you might need evidence, which would be in documentation, to show how well they did or progressed. Patient must be homebound. Another Medicare reality. They must be homebound. Considerable effort to leave the home. Takes a whole lot of people, a special van, special equipment. According to Medicare regulations, if patients are well enough to leave the home frequently, like go to Applebee's, they are able to visit a physician's office for treatment and are not in need of home care. Home health agency must be Medicare certified. So always check to be sure that home health agency is certified. Types of home health services. So there's skilled nursing, skilled observation and assessment. So that implies that the skills of a nurse are required to observe a patient's progress, to assess the importance of signs and symptoms, and to decide on a course of action. So I'm on page 13 in case you want to be following me here. For example, good assessment skills and judgment are needed to detect the signs and symptoms of congestive heart failure early enough to prevent rehospitalization. LVNs commonly perform focused assessments, and a focused assessment is as opposed to a regular assessment. Let's say a patient has pneumonia. So you're going to do a focus assessment where? On the lungs, right? That's considered a focus assessment. You're just focusing your assessment on one particular thing. Yes, you're going to look at everything, but a focus assessment is very important. All right, and this focus assessment would find congestive heart failure early enough to prevent rehospitalization. So, in other words, the nurse can call the doctor and say, oh, I noticed pedal edema, there's some crackles in the lungs, this patient may be headed towards heart failure, would you like to order some Lasix, restrict fluids, what would you like to do? So, skilled observation and assessment. The patient education. So you want to be able to teach the patient, hopefully cognitively they can be taught and that they're at the level of knowledge so that they can care for themselves and relay any information if needed. Performing skilled procedures. Skilled procedures include dressing changes, Foley catheter insertions, and venipunctures. Injecting insulin is not considered skilled. I think I was talking about that a little bit earlier. Specialty home care. So things that are special about home care. So hospital days is a big thing these days in the hospital. They don't want a patient there any longer. If something can be done at home, they can go home and have it done. For instance, IV therapy. So if they need IV antibiotics, they don't have to be in a hospital for that, especially if they're up and around doing pretty good, except for they need that 8 weeks of IV antibiotic therapy. So that would be a specialty home care. And the patient may have a PICC line or some sort of a central line in their chest. And chemotherapy drugs are always given through central lines by registered nurses. And so as an LVN, you need to know that unless you have had IV certification or chemo certification, that wouldn't be one of your roles. But you could certainly teach a dressing change, right? To care for a line. And then another specialty home care is ventilator therapy. So a lot of rehab facilities will not take a ventilator dependent patient. There are a few facilities that will, but they're in big demand because a lot of patients are still attached to a ventilator. And I'm sure this COVID thing has really made that more of a necessity. Ventilator-dependent patients are increasingly being cared for in the home setting. This type of care is complex and should be provided only by nurses and caregivers specifically trained in the use of necessary equipment and procedures. Suction equipment. You'll need a respiratory therapist to check the ventilator settings. So maybe someone to go in and do that. And then, of course, family members would need to be taught what to watch for. If the secretions become foul smelling, or if they're coughing a lot. Some home care needs to be 24 hours if that can be afforded, but all right. Initial assessment of the home environment includes an assessment of all factors important in other high technology therapies, with the addition of an assessment of the electrical and structural condition of the home. So, you know, when we have rolling blackouts, or if you live in a place that maybe has, you know, electrical outages, you've got to be sure that there's a backup battery for these ventilator-dependent patients, because they cannot be without electricity. You know, they need a backup because they have a machine breathing for them. So that needs to be necessitated. Communication among healthcare members. So very, very important. And how would you do that? Because you may not see the next nurse. It's not like at the facility where the next nurse comes in right after you leave, right? They might come in 2 days later. So documentation is very important. What you see, what you saw, what you see, what you saw. That didn't make sense, did it? What is presently there, what you have seen in the past. Documentation. Is it getting better? Is it getting worse? What color were the secretions when you were there? What color was the dressing? How did the wound look? And so you want to document all those things. How was the patient's mentation? How were they talking if they'd had a stroke? And then the other way communication is with the home health care members is they have conferences where they can all talk. These conferences often provide detailed information about the complexity of problems that justify increased visits. So that can be a benefit to the patient because they see once they get together and they put their heads together that this patient needs more than they're getting. So that could be a good thing for the patient. And there's always a case manager that schedules periodically formal case conferences, or actually can also visit the home and check on the patient and be sure that documentation's going well, be sure that the medications are in order. And I've seen a couple of these cases come through the BVNPT where the home health just isn't keeping documentation, or so they're not passing on their information that they have, or the medication, the doctor's orders aren't transferred properly. So you have a special person that goes and follows up on these things to be sure that everything is running smoothly in the home health. So rehabilitation, it's a process of restoration. Restoration to what? Restoration to their best self, the best possible health and functioning of that patient. So that's rehab. So I just want to, if you'll go to page 15, look, it's slide 15 and we're on page 15 I want you to go to. So rehabilitation concepts. Rehabilitation is a process restoring an individual to the best possible health and functioning. Oh, look at that. I said it a couple times, must be important. So also, impairment. What is impairment? We're going to learn 3 terms here that are really important for you to know. So I suggest we're going to talk about them here, and then you just keep going over them so that you understand what they are. What is an impairment? An impairment is a disturbance in functioning. And let's read a little further. Impairment refers to a disturbance in functioning that may be either physical or psychological. An example of physical impairment is paralysis of an arm or a leg as the result of a stroke. So a lot of times an impairment is some sort of a disease process causing the loss of functioning. A stroke, Alzheimer's disease, loss of function. Now, what is a disability? A disability generally refers to a measurable loss of function and usually delineated to indicate a diminished capacity for work. So they're disabled to do the work that they used to do. Back injuries is a disability. And then what is a handicap? Well, a handicap means that an individual is not able to perform one or more normal activities of daily living, or ADLs, because of mental or physical disabilities. So, like a stroke patient may be handicapped in driving a car because of the related paralysis. Remember though, and it says this in your book, on top of the second paragraph on page 15, remember that disability and handicap are not the same thing. A person can be moderately disabled but still manage to perform routine daily activities. Moderately disabled can still perform routine daily. Not easy. It's not going to be easy, but they can do it. People who are born without arms are often able to perform all essential ADLs by using their feet and certain assistive devices. So they adapt. Handicap adapt. Levels of disability. So this is kind of important to know. I know there's a question on the test about this. So let's talk about it. Levels of disability. That's the first time I said that, isn't it? About the test. So level 1. Level 1 is a slight limitation in one or more ADLs, but they can usually work. So they have a slight limitation, but they still can work. Level 1. Level 2, moderate limitation in one or more ADLs. They're able to work, but the workplace may need modifications. Now, level 2 is important because, and when you get a test question about this, read it really carefully. Moderate limitation in one or more ADLs, and the workplace has to be modified, but they can still work. Right? Level 3, severe limitation, they can't work. So know those differences between the levels. And level 4 is total disability with nearly complete dependence on others for assistance with ADLs, and they're definitely unable to work. Okay. So rehab goals. The rehab goal is to return them to the level of function, the best level possible. Ideally, the level that they were at before, not always possible, but restoration of as much as possible in the traditional ADLs. The ultimate goal is to live independently. Not all patients can be restored to their previous state, but you always want to emphasize their abilities and be positive of the things they can do rather than focusing on the things they cannot do or how they can do things differently. Not in their usual way, but they can still get it done. So if you wanted to be a rehab home health nurse, that would be one thing you would focus on. Excuse me. So other rehab goals would prevention of further disability. So one thing that really gets me is when a patient who's had a stroke gets a contracture. That's a further disability. There's no excuse for that as long as if they're in rehab, you as the nurse have them do their movements, right? And then if you're not doing the movement, teach the patient how to lift their arm, move their arm over so that their joints don't become stiff and that their hands don't get contractures. They can open their fingers with the other hand. If not, you can open up their fingers, but please don't let the patient get a contracture. And a secondary disability may be caused by the patient's primary disability. So if a patient isn't getting up and moving around, they can get pneumonia. This is on page 16, prevention of further disability. It involves the prevention of further disabilities or a secondary disability. Example, pneumonia. They get pneumonia because they're not moving around. That's a secondary disability. Decubitus ulcers, again, not moving around, not changing position so that you get a decubitus. And limb contracture caused by lack of mobility. The nurse always plays a key role in the prevention of secondary disabilities. So please remember that, whether it be home health, in a facility, or anything, that we always want to prevent worsening, right? Rehabilitation process can place additional burdens on family members when roles once filled by the disabled family member must be filled by other members. And a lot of times this is cultural. Usually the man is the head of the house. The man usually goes and is the wage earner. If this changes in the environment, some people can adapt fine, but if it's a cultural issue, it's a little bit harder on the family members. So how about the rehabilitation team? So the rehabilitation team, I just want to go back for a second. Did this get missed? Well, let's talk about the rehab team and then I'll be sure I'll cover the other information. Nurses who care for disabled clients must consider the whole person when planning interventions. Difficulty functioning may affect many aspects of a person's life and require coordinated services and several healthcare professionals to the individual so the individual can stay well. Successful rehab depends on healthcare workers considering how the individual functions within the family and working closely with other health professionals towards a common goal. So some approaches to rehab. Rehabilitation patients should be cheerfully encouraged to do as much as possible for themselves. That's really important. Because we want to create independence for the patient. Even if they're not doing everything perfectly, it's a real boost to their self-esteem if they can do it for themselves. So it's just like with kids too. We want to encourage them to be independent, so we don't want to rush and tie their shoes. We want to teach them to tie their shoes. We want to teach them to button their shirt. So same thing, sometimes people have to learn skills or ADLs all over again. And we want to teach them to do for themselves and encourage them to do for themselves. And we want to be cheerful, and praise, lots of praise is very helpful. So rehab legislation. Federal government has passed laws to protect the rights of the disabled. This was the part that I thought that we had forgotten. It seemed like it's a little bit out of order. Sorry about that. So the federal government has passed laws to protect the rights of the disabled. Now, it's pretty important that you know about these acts. The Vocational Rehab Act of 1920. So if you read about that on page 16, so it starts about the first law passed to aid the rehab of World War I servicemen was the Vocational Rehabilitation Act of 1920. This law provided job training for injured veterans. So it all started with veterans. The Social Security Act of 1935 provided additional aid to states for both direct relief and vocational rehab. The Rehabilitation Act of 1973, however, provided a comprehensive approach to problems experienced by the disabled. This act not only expanded available resources for vocational training, but also defined services to be included in rehab programs. So I want you to jump to 1990. And I'm on page 16 at the bottom of the page. In 1990, the Americans with Disabilities Act was passed. This law extended the protection given to the disabled in the public sector by the Rehabilitation Act of 1973. So it was put out there for the disabled in the public sector, not just for veterans. So the public sector had to change. There had to be changes. That's when we started getting wheelchair ramps. Oh, some of you were probably born then. Probably don't even remember this, but we didn't always have special wheelchair bathrooms. We didn't always have wheelchair ramps. We didn't always have elevators large enough for a wheelchair. It didn't used to be like that. They had to have an act in 1990 that made workplaces, doctors' offices, they all have to have bathrooms now with you know, and like what's the word I want? Like not a ramp, but something to hold on to, a rail to hold on to in the bathrooms. And the bathroom stall for the wheelchair accessible had to be bigger than the other stalls. So those were things that had to be everywhere. They had to adapt to the needs of Americans with disabilities. Sorry, got a drink of water. Drink your fluids, everybody. All right, so let's talk about long-term care now. So now we're over on page 18, long-term care. 16,000 nursing homes in the United States. Isn't that amazing? That's nursing homes. Those are classified as nursing homes. There's other types of homes where people live and get nursing care, but a nursing home has a lot more that it provides. nursing home population is about 1.3 million. As we know, the elderly population is a lot. It's required by people of all ages who are temporarily or permanently unable to function independently. So that's long-term care. So when you get out into the facilities, you'll find that not all nursing homes have just old people or elderly people. Sometimes you'll find, I remember we had some 20-year-olds, whether it be from a car accident where they needed long-term care because it couldn't be done at home, whether it be multiple sclerosis, a disease where there is no one to take care of them. Remember, in home health, you need somebody to help take care of the patient, someone living there. Or if they can't do it themselves, that's great. They just need a little help from the outside, which is home health. Or they need a family member that can help. But what if you have no one? Then you need to be put into a long-term care facility. So there's different types of long-term care. There's domiciliary care home. Now this is important to know. Bet you never heard of it before, huh? So let's read about it. It's on page 19. Families providing basic room, facilities providing basic room, board, and supervision are sometimes called domiciliary home care homes. So it's like a domicile, that's a home, right? So it's a facility that provides something like home, but 24-hour care is not provided. So there's somebody that checks in on them. Then there's personal care homes. These are facilities providing medically ordered medications and treatments. They supervise residents in self-medication and provide 3 or more personal services. Then there's intermediate care, and that's custodial care at a level usually associated with nursing homes. Patients often need assistance with 2 or 3 ADLs. Must have personnel available 24 hours a day. They receive no reimbursement under Medicare. Many receive financing under Medicaid or the family pays. It requires an RN to serve as director of nursing and an LVN to be on duty at least 8 hours a day. Now that's not around the clock, right? A friend of mine worked at a facility in Pleasanton where the family paid a lot of money because they couldn't care for the patient, but they needed someone to keep an eye on them, make sure they got their medications. And the RN was the director of nurses. And they tried to have an LVN there 8 hours a day. And it did have CNAs as well to help, patients getting in and out of bed and things like that. But it's not as intense as a long-term care facility. Sorry, talking too much. So now we have skilled care. Facility must have skilled health professionals present around the clock, 24/7. Care must be supervised by a physician, and that physician, there is a physician assigned to the facility, but he may not come and see the patient, but maybe every 30 days. So that's why it's so important. Communication is so important. It requires the services of a registered nurse, physical therapist, or speech therapist. And this is around the clock. So what are the risks for institutionalization? I don't really like that word, institutionalization, but that's the word we're using here. So the age of persons residing in nursing homes, 1% of people ages 65 to 74, 6% of people age 75 to 84, and 20% of people ages 85 years and older. So ADL, as the number of ADL needs increase, so does the risk of needing nursing home placement. And again, ADL, they can't do the activities of daily living. Other factors that may affect institutionalization: financial resources, living alone with or with a family might not be possible, mental illness. It's hard to live with someone with a mental illness. The type of disease process that the patient has, if it's going to be steadily getting worse, a disease that gets worse as time goes by, they need to be institutionalized. And degree of social support. Maybe they don't have anybody else to take care of them. So what are the effects of institutionalization? I'd like to read, if I can, on page 20. And I know you can read it along with me. It's a case study, and it's something I want you guys to always remember. So I don't think I truly understood what depersonalization was until I met Herman. Herman and his wife Christina lived alone in a small house in a northwestern city. Herman was 62 years old and had Alzheimer's disease. I met them while working as a home health nurse. I was asked to look into respite services to help relieve Christina of the strain of caring for Herman. I remember my first impression of Herman formed after reading the chart and talking to the staff nurse about his care problems. He was starting to neglect his personal appearance. The staff nurse said he often put soup on the stove for lunch, then went out to the garden to tend his flowers, forgetting about the soup. This and other images of his functioning created in me a picture of an incompetent and helpless old man. Over a period of weeks, Christina shared many stories with me about who this man was, what he cared about, how they had met, and her deep devotion to her husband of 35 years. Gradually, I was able to see the distorted image I held. Herman was an Olympic gold medal skier from Austria who came to this country as a young man. He held several jobs as a ski instructor and repaired ski equipment until he met and married Christina and moved to the northwestern United States to become the owner and manager of a small ski resort. He was tall and muscular, with an easy smile and a kind word for everyone. He was admired by many in the community for his skill as a skier and his friendliness. He was a good father and family man who was known as the Rock because of all of his family and friends relied on him for advice and assistance. Over a period of 5 years, Herman became more and more forgetful, less talkative, and often preoccupied with household tasks that he would start but not complete. He also failed to recognize many of his close friends and at times would wander off downtown without knowing why or where he was going. Through this, Christina remained fiercely devoted to Herman. Although the strain of the caregiver role was beginning to affect her health, he cared for us for so many years. Now it's my turn to care for him. I was surprised at how my view of Herman changed as I learned more about him. I was seeing him as dependent, helpless, and a burden to his small and frail wife, a view created by my observations of his behavior and what I knew of Alzheimer's disease process, a view that changed radically once I knew more about Herman. I doubt I will ever minimize the importance of learning about the whole patient. And this is what I recommend to you as nurses, to realize this is a person. This person had a family. This person had a job. This patient had fun and laughed and did errands, all the things that you do. They once did, and now they're not able to. So don't ever forget that person that was once there. So you can imagine a person who was once so self-reliant is suddenly dependent on someone else. It must be hard. It must be very hard. So the more prepared the patient is to accept being put into a facility, the better the adjustment. Provide as much choice as possible for the patient. That helps them maintain their independence. Respond to questions and concerns. Please don't ignore your patients. Don't ignore their questions. Treat them like people. Allow the patient as many independent choices as possible. Give them a choice, not just, well, this is what we're having tonight. That's that. If they don't like it, maybe the kitchen can get something else for them. Encourage and assist patients to acclimate socially. In other words, make friends. Go to the big room where they have activities. Encourage them to imbibe in the activities. They play dominoes, cards, there's puzzles, there's books. So we always want to encourage our patients to mingle with others, not become isolated, because that's very depressing. It's almost like a torture, isn't it? So I wanted to read you that case study. Sorry it took so long, but I'm pretty passionate about treating a person like a person, not just a patient. You're like your mother, your father, your brother, your sister. Okay. So some other effects of institutionalization, depersonalization, like I said, just one of many. Just room 304. It's room 304. It's not John Smith. So that's hard for the patient. And it's not very nice for the nurse either. Indignity. So, they don't have any underwear on. They might just have a nightgown on. Their pajamas might get dirty. So for someone who's used to taking care of themselves, to be like that, it's a loss of dignity. So the redefinition of normal, what is normal? It's a new normal. The patient has a new normal. Regression, so once very self-reliant becomes dependent on someone else. I'll tell you a story here. I had a great-grandmother that was very independent, just traveled the world and did all kinds of things. When she fell and broke her hip and found that she couldn't take care of herself anymore, and her family, was not me, but her immediate family was going to put her into a facility to care for her. It was another state. She didn't deal with that. She couldn't do it. Nope. So you know what she did? She took a bunch of sleeping pills and she just committed suicide because she could not bear the thought of anyone else taking care of her. If she couldn't live the way she wanted to live, quality of life, she didn't want to be there. Now, not everyone feels that way, but remember, there are some people that do. And we don't ever want our patients, like I said, to withdraw and not be social. So we always want to encourage them, even if they just come to the nurse's station and we just talk to them, maybe read a magazine with them or read a book, right? Keep them socially active. So promote independence. We always want to do that. Maintenance of function. Get them up to the bathroom rather than just a bedpan. We want to, if we can, okay? You always want to help your patients as much as possible to be independent, to do things, quote unquote, normally. And the maintenance of autonomy, which is doing for themselves. You can do it. You can put your shirt on. It may take them an hour. Let it take them an hour. Where are they going? What else do they have to do? If it takes them an hour, let it take them an hour. Don't rush them. Let them feel like they're doing something. So other principles of long-term residential care: mutually established goals are more likely to be achieved than those selected for the resident. So what can we do for you? How can we help you? What would you like to do, and how can we get that done? Not just, you're going to do it this way. So autonomy, which means it's something they decide themselves, depends on knowing one's place in the world and what roles one still plays within the family structure. So it's important that the patient has autonomy. Families who relate to their elder members reinforce their importance in their family and keep them up to date on family happenings and decisions, support the idea that the elder remains a valued family member. Another thing I might suggest for your patients is if a family member can bring pictures of their family, pictures of what the patient looked when they were younger. You'd be surprised. It helps you give more of an identity to that patient if you know what they looked like before. Maybe if they were in the military, they can have their uniform, a picture of them in their uniform. And you look at the frail man in the bed, and then you realize, wow, he had a Medal of Honor. So don't ever underestimate your patients and think of them as just another person. You don't know what they did, and it's important that the family keep you up to date and keep the patient up to date as well, and a reminder of what they did and of everyone that loves them. So there's some other patient care settings that are available. Clinics, physicians' offices where they can go and have their blood pressure taken or their weight or an appointment, schools, adult daycares. There are adult daycares where if you're taking care of, let's say, your mom, you have a place that you can take her for the day so she can be around other people that are her age. Because if she can't get out and socialize, if you take her to a daycare where there's other adults that can do adult things, that can talk about adults, and nobody knows what it's like to be incapacitated until you are. So for that adult to talk to someone else who's experiencing the same thing, even if it's aging, just the act of aging, you don't understand what it's like when someone ages until you start aging. And then you realize, oh, this is what they went through. This is how they felt. Respite care. So respite care is a place that they can just get relief. Correctional facilities is another patient care setting. A lot of the people who are in jail are really not there for something they did wrong. A lot of them are there for mental reasons. Maybe you'll be lucky enough to tour the jail. All right, so here we are at the end. I want to say one thing about autonomy. An example of autonomy, remember I said autonomy is making decisions for yourself. So advance directive, which is a form that the patient can fill out what they want if they're failing, who they want to make decisions for them if they can't make decisions any longer. So they can choose CPR, no CPR. They can choose, make some choices. So that's really important. That's the advance directive. Autonomy depends on knowing one's place in the world and what roles are still holds in the family structure. I mentioned that before, but I'm going to say it again. So let's try a question here. So which of the following is a true statement about home health versus hospital care? So I'll give you a minute to look at that and think about it. Which of the following is true about home health versus hospital care? So the correct answer is 1. Home health nursing provides more direct care to patients than public health nursing. So home health nursing blends direct nursing care and community health nursing. The main difference between home health nursing and traditional public health nursing is that home health nursing provides more direct care to patients. Although giving direct care to a patient, an individual, is an important part of home health, a more important nursing role is to teach the patient and family to care for themselves. All right. Now, before we go on to question 2, because it cuts me off right after the last slide, so I want to tell you that at the end of the chapter are the key points, and those are pretty important. There's a lot of key points here in this chapter that are important to know for the test and in general. Also, the review questions for the NCLEX exam questions. Now, if you go to Evolve Student Resources, you will find all the answers to the NCLEX questions. So I would go through these NCLEX questions, see if you can answer them at the end of the chapter, and then you can go to Evolve Elsevier, your Elsevier account, and look under Student Resources, and you can find all the answers. You can find answers to the NCLEX questions. You can find answers to some put on your thinking cap questions. When we get on into the book, you'll find the care plan questions are there. So utilize Evolve Elsevier. All right. And then when we talk, you can always just jot down questions if you want to ask me. If you can't find it, I'll be happy to help you find the resources you need so that you can be successful in med-surg. All right, let's try question 2. Which of the following home health care services are not considered to be skilled? So the answer is number 2. Nursing, physical therapy, and speech therapy are all considered skilled home health care services. So looking at this question, maybe you didn't know the answer, but you knew which ones were skilled, didn't you? You knew nursing was skilled. You knew speech therapy required a skilled person to do speech therapy, and you know physical therapy is skilled. They have to go to school for that. They have to go to school for social work too, but it's not a skill that they can really teach the patient. They can help get things together, but the other 3 are skills. So by process of elimination, you can know which one is not. So when you answer questions, and we'll talk more about this for tests, you can look like which one's not like the others is a way to answer a question. So nursing, speech therapy, and physical therapy all offered at acute care facilities, offered to the patient, but social work is not always. So that one's a little bit different than the other 3. Plus, reading the chapter helps, right? All right, so I look forward to seeing you all and talking to you, and we will meet. Well, I will have met you already by the time you look through these slides, and then on Thursday you can ask me questions about these slides if you want. And you can always ask me questions by email too. All right, thank you.